Hello, everybody. I am very, very excited to have Ruth Lanius as my guest today, um, who I would assume needs very little introduction. She is an internationally known researcher and clinician who I think you still are distinguished by being an expert in both. Something that we we see very little of that relationship between clinician and researcher. She is the author of many, many scientific papers, many books, and the most recent, you and Bethany Brand collaborated on Finding Solid Ground, right?
Yeah, and then there's one more after that that I collaborated with my group.
Oh, cool.
Yeah.
Even a newer book
Yeah.
called
Sensory Pathways to Healing from Trauma, Harnessing the brain's capacity to heal.
Fantastic. And I bet that Frank Corrigan is one of the co-authors.
No, he's not actually. It's three of my group members. So the co-authors are Shireen Harishran, Brianne Carney, and Benjamin Pandev Gerard.
Oh, fantastic. So, right, you have amazing colleagues that you've worked with over the years.
Absolutely.
Yeah, yes. Oh, right. So I was actually adding up the math today and realizing we met at Bessel van der Kolk's trauma clinic
Yeah.
called the Trauma Center. Um, I went to the Trauma Center to become a supervisor in 1995, exactly 30 years ago. And you came shortly after.
Yeah, I came in 1999, Janina, and I remember you.
Oh, I remember you too. It was so great. I mean, it was kind of amazing because you were Canadian and you were a psychiatrist and those two features um, made us feel we must be very important to have this very important person um, learning with us.
Yeah, it was a great time. I
Oh,
was only there 3 months, but it felt like, at least a year's worth of training. Yeah, it was so rich and so exciting. And yeah,
uh,
the community was so great. I learned so much from everyone at the trauma center. Yeah, and it was just, yeah, I think a really wonderful community, right?
right. It was. And, I'm always impressed when I think back because on the clinical team, of course, you and I were not seeing patients.
Mhm.
We we were I don't, you were I mean, I was supervising. I think, were you technically a fellow?
No, not quite. So I was still in my residency, so I was still training to to be a psychiatrist, and there was a 3 month rotation I could do outside
Oh,
my own residency program. So I actually saw some patients in the EMDR study.
oh, that's great.
Yeah, yeah,
Yeah,
yeah.
yeah. And for people who are not familiar with the trauma center, because it's now a piece of history, the trauma center was the one of the first trauma clinics ever established in the US
Mhm.
by Bessel van der Kolk. And it was an extraordinary place.
Yeah, it really was. And people from so many different treatment directions really coming together and sharing their experiences. And the level of curiosity was just
Yeah,
amazing, right? We all wanted to learn, we all wanted to be better therapists. And yeah, it was an incredible atmosphere.
right. And we weren't blaming the clients
No.
being difficult. We weren't blaming ourselves. I remember the first meeting I ever went to at the trauma center. They were discussing the suicide of one of the staff members' clients. And I was used to to systems in which the therapist would have been sort of under interrogation
Mm.
about what they missed
Mhm.
and what could have been done differently. And instead, everyone was grieving with her,
Mhm.
right? And supporting her and saying you did the best you could. And I thought, what kind of place have I come to?
Mhm.
It was so human.
Yeah, which is exactly how it should be, right?
It's absolutely, absolutely.
Yeah.
Yeah. And then when you finished your residency, was that when you started doing your research?
No, I actually started doing my research during my residency. So I was very
In case you
lucky.
didn't have enough to do.
I was very lucky to meet Peter Williamson, who was one of my mentors in London, Ontario. And I actually started in neuropathology. Don't laugh, Janina, because I had this research background in neuroscience and I didn't have a lot of clinical experience. And so I thought, what specialty would allow me to continue to do research? And so, because I didn't have any clinical experience, neuropathology
There you go.
sounded good at the time. And then I started doing my residency, and the first year was an internship where you had to rotate through all the basic rotations in medicine. And my first rotation was in psychiatry. And so I worked on this wonderful inpatient unit. It was very small, 16-bed unit, very supportive, and I just loved being there. And it turned out that most of the people there were actually traumatized individuals. They weren't labeled as such,
Right.
but they were. And my brother was a psychologist, and he said, you got to read Bessel van der Kolk's work. So I started reading Bessel's work. And so I was
Yeah.
able to figure out, oh, this makes sense how these individuals are presenting. Trauma is really at the root here. And so I learned a ton from the people I worked with. It was
Yeah.
really gratifying. And very early on in this rotation, I realized, my God, I've made the wrong decision. And I've got to get out of neuropathology, which was very hard at that time because you couldn't take your funding from one specialty to another.
Oh,
So I was very lucky to meet Peter Williamson, who was a schizophrenia researcher, and he was sort of a pioneer in neuroimaging. And so I talked to him. I said, this is my situation, and I think I've made a mistake, and I'm just loving psychiatry, and I would love to, continue to do research as well. Would you be able to help me switch to psychiatry? And sure enough, he did, and
oh,
I was able to switch. And then he was generous enough to fund my first neuroimaging studies. So he really encouraged me
wow.
to, research the brain. I was very curious about, how these individuals had adapted to horrendous experience. And he said, yeah, I'm working with this psychologist who can help you with the statistics of neuroimaging. I also have an imaging analyst who can help you. And so he
Oh,
brought me into his group, and I
it's
was
like you
able to
were
start.
handed the silver platter.
Yeah,
Oh my gosh.
absolutely. Yeah. And that's when it all started.
Right, 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 right. And I mean, that's what I remember about the first time I heard you speak, after, however many years later, where you were showing your neuroimaging
Yeah,
of the couple who from the car accident.
that's right.
And it was so amazing. Uh, because, because neuroimaging was still a relatively new idea.
Absolutely. Yeah. And I remember I scanned the car accident couple the morning before I left for Boston to my rotation. Yeah. So I was actually in a rush to get out of the imaging lab to catch my flight to Boston.
Amazing,
Yeah.
amazing.
And they were a little bit later, but the first individual I imaged, was a severely traumatized woman, with severe dissociation. And, in the literature at the time, people were only included in neuroimaging studies if they had an increase in heart rate when they recalled their trauma. And so she was the first person we studied. And I remember reading the script of her trauma, and I was sitting beside the physicist who was running the scanner, and we actually had a bet on how high her heart rate was going to go. And so as I was reading the script, her heart rate started to go down. And we looked at each other, and the physicist said to me, "Do you think she's kind of gone, Ruth?" And I think, yeah, I think so. We'll talk to her after and we'll find out exactly what happened. And sure enough, she told us that, she couldn't stay in her body. She had to detach from everything in order to tolerate hearing the script. And that was the first individual we scanned. And right away I knew, oh my God, we got to separate these groups. Some individuals will have, hyperarousal response while recalling their trauma, and other people will respond very differently,
Right.
which
Right.
was very controversial at the time,
Absolutely.
right?
Even though, this is the amazing thing, even though if you'd asked a group of therapists,
They would have said,
they
of
thought,
course.
of course, we see both.
Yeah, yeah, absolutely. Yeah.
Yeah,
Yeah.
amazing, amazing. And so much. You've learned so much about the brain and trauma and have helped to educate so many therapists. I feel like the influence of this neuroscience research on what clinicians actually do is so profound.
Yeah, and clinicians are so curious, right? They really want to know, right? I find that so impressive. And
Oh, they're
because
desperate.
yeah, but they really try to bring together the clinical and the research side, right? Where in other areas it's still very split, right? And you talked about this earlier, Janina. It's so important to bring the two together, right? You can't do PTSD research or really any research in any emotional difficulty without knowing the person who suffers, right? Without really understanding, subjective suffering of the individual, right?
Right. Right. And before brain scan research, I think there was a sort of general acceptance since Freud that we would know what was happening in the individual's brain because they would tell us the story.
Hmm.
They would describe their feelings.
Mhm.
And then Bessel's first brain imaging study showed
Hmm.
the prefrontal cortex going offline
Yeah.
when the subject started having trauma responses. So, so then, um, then we knew. That taught me. That was so rich. I
Hmm.
still teach about it constantly.
Yeah. Yeah.
Right? And to realize that traumatic amnesia is actually an erroneous concept. If the memories don't form, that's not amnesia.
And we always have sensory imprints of them, right?
Right.
But we can't put them into words, right?
Right. Exactly. Yeah. Yeah. What's the work you're doing now?
Yeah, so we're excited about a number of projects, Janina.
Not surprising.
One is together with Bethany Brand and Hugo Schielke, and we're continuing to research the Finding Solid Ground program that we, really helped individuals with around the world and really tested and learned from the most severely traumatized individuals who were highly dissociative, We had no exclusion criteria, which is very unusual for research, right?
Very unusual. Let's underline that 10 times.
And so people who were, suicidal, parasuicidal, who were using substances, and, together with those individuals, we developed this program. We got a lot of feedback, and we're finding, some really strong results, which, is amazing and humbling, right?
It's wonderful.
Yeah,
Yeah, yeah,
because this population has been so neglected. I mean, this is the population you focus on in all your trainings, right? And I think we all need to work together, right, to help this population because they always fall between the cracks, right?
right. Absolutely. Absolutely. And so it's actually a population I've always loved.
I know.
I
Yeah.
I I enjoy them.
Yeah. So do I. And so does our team. Yeah.
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 Yeah. Yeah. That's wonderful. So that's a resource that all of our listeners can keep in mind. Finding solid ground. You can just Google it and go to Amazon, right?
Absolutely. And yeah, we're just in the process of getting our final results in, and they look really promising. And yeah, we've been humbled by this whole process. And we're so thrilled that, yeah, a lot of people have had such profound experiences. And we've had so many, just first person, reports about, how this program has changed people's lives. And I think what I've really learned, and hindsight's always 2020. And when I first started doing this work, I was running DBT groups that were adapted to complex trauma. And of course, in DBT, you start with mindfulness.
Yes.
And what I learned there, and we were treating the highest users of the mental health care system. And what I learned was that, for the highly dissociative individuals, the first 6 months in the group, they retained nothing. And now, having gone through the Solid Ground program and really learned from the traumatized individuals, and what we really learned was that you have to do grounding first.
Mhm.
Grounding, grounding, grounding before you do other things. And yeah, now in hindsight, I understand why my patients years ago, right, didn't really get anything out of the first 6 months.
Right, right. And that I think is still the Achilles heel of DBT is that it takes a working prefrontal
Yeah.
cortex uh,
Yes,
to make good use of.
absolutely.
Right.
Yeah. So yeah, that's been profound, and now it kind of make, of course, right? You think, well, yeah, but so to really, see individuals go through this process of grounding and, feeling held by the earth, gaining that gravitational security, is amazing, and how that really sets the foundation for them then to build further skills.
Right, right.
Been amazing. Yeah.
So cool, so cool. And uh and your other projects.
So the other project we're working on is in collaboration with Frank Corrigan, and we've been researching deep brain reorienting therapy, which is a trauma processing therapy that really, I think, starts at the foundation of the trauma response, which is the orienting response. And then it works with the shock related to the trauma, and then it processes the pain and the affective responses to the trauma. And I think what's beautiful about it is that, it's very sequenced. And I think Frank has really done a good job of slowing down that sequence to make it more manageable for individuals.
Right,
And
right.
so here I have also been very surprised at the individuals who've been able to tolerate this treatment. So I would say this is not a treatment for individuals we had in Finding Solid Ground. So this is not a treatment for suicidal individuals, individuals who are very parasuicidal, individuals who can't ground yet.
Right.
But what floored me, Janina, was that we had a lot of 65% of our sample has a complex dissociative disorder.
Wow.
And so these were sick people. They had been suffering for decades. And, within 8 sessions, they did a significant piece of work. That
Yeah.
doesn't mean they're cured. And, I don't want to, we all know working with this population, right, that we need, multiple pieces of treatment. But
Right.
these 8 sessions really offered them a piece of work they could do.
Right.
And I think the most striking finding that we found was that they were able to start re-inhabiting their body after
Right.
a year.
That is it's so exciting. I've known Frank Corrigan
I
since
know.
2003.
Yeah.
So almost as long as I've known you. And I'm so impressed because he kept talking for years about what was happening in the brain, half of which I couldn't understand, but I was totally fascinated.
Yeah.
And then for him to put together what he saw happening in the brain with the clinical techniques
Mhm.
of deep brain reorienting was just so, it just felt like what a beautiful fulfillment of a life's work.
Absolutely. And now looking at the clinical results but also the brain imaging results, I would never have dreamt of what we're finding and how the brain can really reorganize and synchronize the different levels of the brain. So it's been really humbling and beautiful to watch.
That's so cool. I,
Yes.
yes, uh, I'm so happy for him.
Yeah.
And it's so great that you had the ability to to make the research happen.
Yeah. Well, he taught me deep brain reorienting, and then I took it to some of my most severely dissociative clients who I'd seen for years who had plateaued. And so I said, would you be interested in trying this with me? And almost all of them came out of their plateau. So I thought, wait a minute, there's something here. We've got to study this. So I went to my team. I said, guys, we got to do this study.
This is exactly why clinician researchers are so important,
Absolutely.
right?
Yeah. It
Because
needs to go hand.
because I could come out of doing a piece of work and say, oh my gosh, this has to be researched. But I wouldn't be able to mobilize a research team.
Yeah,
But
but you could collaborate with people, right?
yeah,
You've
yeah,
got, yeah.
yeah. Right. It's possible. I'm collaborating on a research project on my model,
Mhm.
trauma-informed stabilization, with a hospital in Norway.
Yeah.
Um, and and it's going beautifully. But what it came out of was they're saying, um, would it be okay if we research this?
Yeah.
I say, yes, absolutely.
Yeah.
Uh, that's so great.
And then our most recent project, and you'll be very familiar with this, Janina, is looking at Liz Warner's sensory motor affect regulation training, her SMART model. And this really relates to our most recent book, Sensory Pathways to Healing from Trauma. And of course, Liz has talked for many years about how, if your prefrontal cortex is offline, how you can find the right entry point for treatment, right? And so she's shown beautifully, and we've seen this for years, how using sensations and movements can be a great way to really form the entry point to trauma treatment, which then helps to synchronize the brain and bring online language, right? And bring online connection.
Right, right. And this is smart is for children, right?
Yeah, and so we've adapted it to adults in collaboration with Liz, and Liz is also starting to use it more in adults. And so it's really getting to those sensory pathways to healing from trauma. And so we're very excited about this and to see, how adults do with this.
Wonderful. I mean, it sounds in many ways similar, not identical to, but similar to sensory motor psychotherapy.
Absolutely. And I think there's a lot of overlap. And, there's a lot of overlap in all these different treatments that we have to keep in mind, right?
Right.
I think the difference is that SMART started in children,
Right.
right? So it starts even more basic with these sensations and movements than sensory motor psychotherapy. Yeah.
Right.
Yeah.
Right. And I think there's much more of a um, occupational therapy uh, contribution to
Absolutely. Yes. Yeah. The whole sensory processing
right.
field. Yeah. Jane Kumar and others. Yeah.
Right.
Yeah.
Right.
Yeah.
Oh my goodness. Well, we have come a long way. That's right. It's extraordinary. If you
Absolutely.
think about how much we knew in 1999,
Oh, it's wild, right?
yes, it is wild.
Yeah.
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 And you've done so much training over, around the world, and it's so amazing to go to groups and yeah, just they have a different level of understanding because they've trained with you, right?
Right.
Yeah.
Right. Well, that's that's why I'm doing what I do
Yeah.
because because I've had this mission, really the same mission that Bessel has, and you have too, to really get information about trauma out to a wider and wider
Absolutely.
population so that survivors learn about trauma, not just professionals, and
Exactly.
and that the kind of the sophistication of trauma training I mean, trauma therapy keeps growing.
Absolutely.
And I feel like no matter how much I teach, it is still hard
Absolutely.
to 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 change the paradigm of you talk about the story and you'll be okay,
Mm.
as opposed to you you notice you ground, you notice the sensory and somatic elements as your entree. Um, in the case of my work, you notice the parts.
Yeah.
That is still something that feels novel. And
Yeah.
I want, I want what you do and I do to be old. Like I want
Yeah.
everybody to know that and then build on it.
Absolutely. And everybody needs to know all those parts, right?
Right.
From top to bottom,
Yeah.
right?
And the thing that's so hard is, you know, very few therapists have the budget to train in all these methods, but it would be a wonderful thing to be trained in all of them.
Absolutely. Right.
Yeah.
I think the more techniques you have, the more integrative you can work, right? Right.
Right. Absolutely.
And yeah, we
Abs-
all need to know from sensory input to part work, right? In order to put it all together, right?
Right. And do you think we'll ever be able to make the brain scan technology inexpensive enough that you can do before and after brain scans as a routine feature of psychotherapy?
Maybe not as a routine feature, but I think there'll be enough data sets, over the next 5 to 10 years that I think we can really look at different therapies and how they affect the brain.
Right.
Right now we're only looking at the clinician-administered PTSD scale, which is great, but it's also not very subtle, right? And
Right.
so I think this is why we're seeing that, most therapies have a similar effect size, right? But I think where we can see differences, and this is my hypothesis, is looking at, how the brain changes.
Right. Right.
And so I think that's, something important in the future.
Yeah. It would be wonderful
Hmm. Hmm.
to be able to do that. Yes.
Yeah.
Yeah.
And really ask the question, what works for whom and when, right?
Right. Absolutely.
Right?
Absolutely. And do you think there's any way we can get around the fact that that information, I mean, if you read the the research papers, you can see who was ruled out as a subject and who wasn't. So, but when people hear, oh, that's an evidence-based treatment, they don't read evidence-based on whom, on what subjects.
Mhm.
And it drives me crazy when, when, you know, when most subjects are ruled out and then a study uh, has a good statistical outcome and we say, oh, it's evidence-based.
Mhm. Absolutely. And I think this is why we need real world evidence, right? So we have these highly controlled studies. And that's great. Everybody picks the best therapists. It's highly controlled, right? But real world evidence is just as important, right? So when you take it to populations that, have multiple comorbidities, that, like the Finding Solid Ground population we studied, right? Who are really the sickest of the sick, who would not get included in most studies.
Right,
Yeah, we need these real world samples and we need to understand what happens there just as much as we need controlled studies, right?
right, right. Absolutely.
Yeah.
Because, because if if we're trying to, if we're trying to be successful using a treatment that has only been tested on high functioning clients, the therapist is going to, the treatment's going to fail. The therapist is going to feel some loss of confidence,
Absolutely.
and the clients are going to feel like it's their fault.
Exactly.
And
They're going to
that's,
feel like a failure. Yeah.
yeah, yeah,
And that's
yeah,
not okay.
that's not okay. Yes, I I agree.
Yeah. Yeah.
Yes. And that's when it's so good when therapists can bring in all these other modalities.
Absolutely. Yeah.
Yeah,
And
yeah,
that's our challenge for the next decade, I think, to really provide the evidence that we can show, right? This is why these treatments work, and yes, they work, right? I mean, they're all neuroscientifically guided, and we've seen them work in clinical practice. So now we really have to show the evidence, right? Because that's the only way we're going to get treatments covered by insurance companies, right? We need the evidence, right?
absolutely.
Yeah.
Absolutely. Well, let me just, I know we have to stop momentarily, but let me ask you the question that I still puzzle over because I get asked about it all the time. From a brain perspective, um, what is it about psychedelic treatment that is effective? Or do we not know that yet?
Well, I would say we don't really know it, but I think there's some clues, and there have been, quite a number of brain imaging studies. And I'll just talk about one brain network, which is the sense of self network, otherwise known as the default mode network. And psychedelics, I seem to really affect that sense of self network.
Oh,
And
cool.
So I think that may be one underlying mechanism, and I think they perturb the brain. They push it out of, its normal state, and so it can start to form new connections and engage in some shifts. And I think that helps the psychedelic process, just
Oh,
in a nutshell.
yeah, yeah, no, that makes perfect sense. And that the psychedelics disrupt the kind of habitual
Mm.
functioning of the brain.
Yeah.
Yeah, love it. So glad I asked.
But I think it's a really exciting time, right? And
Yeah,
a time full of hope, right? And I think we've made a lot of gains. We've got a lot more gains to make, but yeah, I think there's a lot of hope
I
in
think so too.
this time. Yeah,
Yeah, yes, thank goodness.
yeah,
Since trauma is not getting any less common.
exactly. Yeah,
Mm.
yeah.
Thank you, Ruth. Oh, it's so good to talk to you.
Thank you, Janina. It was a real honor to be with
Sure.
you. And thank you for everything you have done and continue to do. We're all very grateful to you.
Oh, and I feel exactly the same way. All right. Bye-bye.
Yeah. Bye bye. Thank you so much, Janina.
You're welcome.